I'm proud to introduce my colleague, Dr. Dheeraj Kapoor, who is a senior and very well sought out of a speaker in the field of endocrinology and diabetes, who is basically working in the Artemis Hospital. And he'll be talking upon the topic empowering heart failure, care in type 2 diabetes, focus on the SGLT2 inhibition. Over to you, Dr. Dheeraj, please.
Thank you so much, Bhanu sir, for that very generous introduction. So, at the outset, I'm honored to be from the same institute which has produced stalwarts like Professor S.K. Magnu sir, and I'll be talking about heart failure basically and the inhibition of SGLT2. Now, this is a case of serendipity, which means an accident by chance and a good chance. So, we sought after controlling sugars and we ended up protecting heart and the kidney in addition to glycemic control. So 1835, fluorescence was discovered, and then 2008 happened that because of certain developments like the drugs like rosiglitazone and the sulfonylureas, and diabetes being a cardiogenic state, people said that you must have COPD trials to see that the drugs are safe. And then came a flurry of researches, and empiric outcome basically changed the way we look at diabetes. And I was there at the venue it presented, and a staggering reduction in heart failure. There was a huge uproar in the crowd, both of excitement and happiness. So, just to set the ball rolling, that it results in reduced CB death in patients with established ASCVD. That's what the empiric outcome told us. 99% people had CVD, 1% did not, and there was a 38% reduction in the population. However, we know that Asia and Southeast Asia, more than that, are the epicenter of diabetes. The Asian subgroup analysis showed a staggering 56% reduction in events as compared to placebo, and the graphs had begun to separate as early as 3 months, and by the end of actually 48, the distance between themselves, showing the film movement. Now, in patients with evidence of heart failure, empagliflozin fared 37% better, and in those without heart failure, again 37. So, irrespective, now we all know that we've been seeing the echo reports, and all of them report at least a type, the class 1 or the LV1 dysfunction in the diastole. And we always thought that these cardiologists are over-reporting, but we now understand that the elephant was always in the room. So, in the empiric outcome, there was a 21% lower risk of MI with empagliflozin. The major adverse events, primarily both the MI as well as the need for CB therapy. In the ensuing 3 months of hospitalization, again, there was a reduction in the empagliflozin group as compared to those on placebo. So obviously the August gathering here knows much better than me, but just to set the ball rolling here, we have HEF-REF less than 40%, HEF-PEF more than 50, the HEF mild reduced, which is 41. And then this entity of the improved EF, which means baseline less than 40 and more than 10% point increase in the ejection fraction. So the emperor reduced, wherein most people were less than 40, both diabetic and non-diabetic. And this is where the beauty of this drug lies. So CB death or heart failure, 25% reduction. First and recurrent heart failure, 30%, and the EGFR slope showed a decline. Now, initially, one must understand that the GFR is reduced by these drugs because of the afferent arteriole constriction, which reduces the pressure in the glomerulus, and therefore the podocytes are preserved and the decline in GFR actually is restored or aborted. Now, in functional class, from 4 weeks onward, there was improvement in the NYHA class, improvement in those with empagliflozin, and actually deterioration in patients on placebo. So if you have to give empagliflozin, it is at this stage where you could possibly salvage from the mitral standpoint. Now, this is a meta-analysis of both the EMPEROR reduced and the DEPA-HF trial, and it showed that across patients with diabetes and without diabetes, there is an improvement, or the risk of CP death and heart failure goes down. So without diabetes as well, and this is a breakthrough, I guess, in cardiology. Those receiving ARNI, well, EMPEROR reduced fared very well, but those not on ARNI, EMPEROR and DEPA-FF, both the diamonds are to the left of the line of unity, showing statistical improvement in the outcomes. All-cause mortality, so DAPA-HF fared better. And I tell you what, that DAPA-HF took patients which we endocrinologists see as a garden variety, those without evidence of clinical evidence of heart failure and CVD. And of course, cardiovascular death, again, reduced in the DAPA-HF. Now, the clinical kidney outcomes, EMPEROR fared better, and what they studied was a reduction in the decline of GFR, ESRD, and renal death. ESRD, GFR less than 15, or those requiring renal replacement therapy. So, empagliflozin has fared better in most situations. So, as per the ESC guidelines, from my standpoint, just the line number 4, dapagliflozin and empagliflozin are recommended for patients with HFrEF to reduce the risk of heart failure, hospitalization, and death. Now, ACC a bit this year only. So, contraindication, we must be cautious. In the exuberance of a new molecule, we should not start giving it to every Tom, Dick, and Harry. We must understand that HFrEF less than 40%. Number one, type 1 diabetes, it should not be used. EMA has approved it. That's a matter for a different day. But from what we know, type 1 diabetes, avoid, and on dialysis should not be given. I would not give it in pregnancy as well, although it's a caution given here, but I would not be doing it. And of course, those who have had a prostatitis or an infection in the mycosis, I would be very careful. Also, I would not give it to very high HbA1c patients, because more glycosuria, more infections. Interestingly, it works very well in a population for that 8.5%. The beauty of this drug is that those drugs for HFrEF, this drug will not require any dose modification. You know better about ACE inhibitors, ARBs, ARNIs, aldectones, epirinones, all of that, that they may require modification, but these drugs would never require that. So this is a history from our own country, where even the patient with HFpEF, which means the elephant in the room, there is an increasing trend towards mortality with the passage of time. So how does this drug act? Number one, controls glycemia. That has to go as number one. Number two, natriuresis. Number three, diuresis. Number four, reduction in blood pressure. Number five, weight loss, specifically in the visceral area. Although there are now studies about the lean mass loss, but the visceral area, and which means that you reduce the visceral fat producing interleukins, TNFs, vaspins, resistance, and therefore reducing insulin resistance. Also, this drug improves the lipid profile. It increases LDL, but increases HDL more than that. It reduces triglycerides, which means it reduces the small dense LDL, which is so important in our population. And it causes ketosis, and you know that ketones are a very, very good fuel for the failing heart. On the molecular level, it reduces the cardiomyocyte stress, reduces inflammation. We know that diabetes is a chronic pro-inflammatory state. It reduces myocyte stiffness. It reduces the matrix remodeling and the concentric hypertrophy. So, as they say, it cleans the pump, which is the heart, the filter, which is the kidney, and the pipes, which are the blood vessels. Emperor preserved the EF more than 40%. Empagliflozin versus placebo. The groups matched with respect to NYHA class, heart rate, BMI, and the ejection fraction, blood pressure. Two-thirds of population had more than 50% of EF, and 21% reduction in CV death and heart failure. The graph again began to separate maybe around 2 months or so and continued till 36 months. So, age less than 7 years, both genders, fine. But look at the race, the third, Asian, and the region, number 4, Asia. This is what we are most interested in while managing our patients, and they have both shown a significant reduction in the clinical outcome across the subgroups. So, EF less than 60, unequivocal, more than 60, benefit is there, but did not achieve significance. Diabetic, non-diabetic, GFR, all of them faring very, very well. Across the use of drugs, so whether using ACE inhibitors or ARNIs or level of the pro-BNP, across all of them, this drug has worked well. Reduces heart failure hospitalization by 27%, and again the early shifting and the graph drawing apart. Did show a reduction in the decline of kidney function. However, the outcomes, the major adverse renal outcomes did not achieve a significant change, although they were reduced. So, primary endpoint, CV death heart failure, 21%, significant. Secondary endpoint, first and recurrent heart failure, again 27%, significant. And of course, the EGFR slope, 1.37, lesser than the placebo, again significant. So, the primary composite outcome, heart failure, 29% reduction, composite 21%, CV death 9%, but not significant, and therefore the composite outcome which achieved significance was primarily driven by the heart failure hospitalization. Side effects, well, I would be concentrating on the hypotension, the UTI and GTI. We've been told that UTI depends upon hyperglycemia and GTI on glycosuria, and there is no doubt that there is an increase in glycosuria. We have published a paper in IJEM, and we have shown a 24% increase in mycotic infections in patients on this drug, the gliflozins. And this is despite the fact that we've been encouraging hydration and hygiene in all patients. A DKA was a scare, but if it is properly chosen, not to be given to type 1 diabetes, to be avoided during hospital stay, and not to be just under 48 hours. If you take all these precautions, hydrate the patient well, there is no reason that why these patients should go into DKA. And of course, BMI should be considered. It should not be given to patients in catabolic state, which means frank glycosuria, weight loss, polydipsia, all of that. So patients with heart failure, more than 40%, impacted for the reduced composite death and hospitalization by 21%. Benefit was consistent across all groups and heart failure hospitalization. So Emperor Preserved is the first trial to show unequivocal clinical benefits with the drug in patients with heart failure and a preserved ejection fraction. So, wherein for HEF-REF you have ARNI, ACE inhibitors, eplerenone, beta blockers, and gliflozins. However, for uh, HFpEF, the foundation therapy is gliflozin. Thank you all for your attention.
Thank you, Dheeraj, for a wonderful exposition of the SGLT2 and the cardio protection.